Thank you all very much, and thank you first to the AAPM&R and the AAPM&R Planning Committee for allowing us to kind of have a creative session like we have today. I'm Matt McLaughlin. I'm a pediatric rehab doctor in Kansas City, Missouri. I'm not Kansas City, Kansas. For those of you who have questions as to the difference between Kansas City, Missouri and Kansas City, Kansas, is the difference between culture and agriculture. And so that's a joke from a Missourian, but I'm, as I said, a pediatric rehab physician, and interestingly, what do I have to say about precision medicine? I think a lot of us have heard about the word precision medicine, but I don't know that a lot of us are practicing or know quite what it means. So first off, disclosures, I'm currently funded by a T32 clinical pharmacology fellowship program. That's where I achieve and learn an awful lot about how to implement clinical pharmacology in the field of PM&R. I'll be discussing pretty much every medication in this talk is off-label, as I think we all understand the challenges and complexities of us achieving FDA indications for any of the medications we truly use in PM&R. And thirdly, if you know my mother, anytime I confess or disclose something, she will wait until I stop talking. And so I have to disclose everything. The ultimate disclosure I have is that in 10 years of medicine, 10 years of being a physician, I've never dosed a patient the correct way. I've never prescribed a medication the right way. And I'd almost put a challenge to you all to say, that you all have also not dosed a patient the correct way. What do I mean by that? And before we get to that, to calm everybody's nerves, here's a nice Kansas sunrise. For those of you who live in Kansas too, I hope I didn't offend you too much with this beautiful picture. Doesn't get you back on track. But why do our patients not respond to the medications that we give? And I think a lot of that goes back to how we're trained. We get trained to give a dose of a medication, right? We are said, 10 milligrams of baclofen is what this patient needs. We're not talking about how much response we're getting with each dose of medication we're getting. We're only giving a dose of medication. So to get from this section, which is dose, all the way over here, which is response, there has to be a lot of things that happen within that. From dose, we have to achieve the right level of exposure of that medication, meaning absorption, distribution, metabolism, elimination of a medication to get to a level that we reach the target receptor site, in the case of baclofen, GABA B, right, to then achieve a measurable clinical response on the other end. And so for our patients who we're giving a single dose to, we may end up with differing levels of exposure based on so many different factors that are each individualized. Nothing, I think, shows this better than a pediatric study that was done in 2014 by He et al., which is from the Best Prescribing for Children's Act, which essentially shows the variability of the single dose of oral baclofen in pediatric patients. The same thing happens in the adult world. But if you were to look at the top right portion of this, underneath 60 milligrams daily dose of oral baclofen, you have up to a 5 or 6-fold variability in the level of exposure that you get when you're prescribing oral baclofen. So when that happens, would we not also expect that there would be a 5 or 6-fold level of variability in the level of clinical response that we would have with this same medication? If we are not achieving the targeted level of exposure, how are we ever going to get to the same level of clinical response? And I think that is behind the whole crux of what I mean when I'm talking about precision medicine. But I've heard precision medicine called so many different things. I've heard it called individualized medicine, and I think people take offense to that because each patient I see, I feel is an individual, right? I treat this person, I feel they're an individual. I treat this person, I feel they're an individual. And I treat this person, I feel that they're an individual. And I change various things about each time that I see them. So I think individualized medicine had caught on, but I think it's a big misnomer. Then I hear about personalized medicine, and I feel like each encounter I have with each one of those individuals is very personal. And apparently, whenever I become a certain age, my dad assures me that my encounter with physicians as a patient will become very personal as well. My mom says that there's a similar level of discomfort that happens when you're female and have to go see your physician when you're a patient. But what I'm really talking about is precision medicine, and that's finding the right dose for the right patient at the right time. And how do we do that? We use several different factors, genetics being one of the things now that we have access to that we've never had access to before. Whenever we used to check whether or not a liver is functioning, we would check an AST or an ALT. And I think a lot of us know that that does not correlate with liver function. It may correlate with liver injury, but may not correlate with liver function. And so for the first time ever, we've been able to look at these medications from a very different perspective. What is the true function of the CYP enzymes within our system, as opposed to whether or not an injury is happening to the liver? In pediatrics, we get a lot of patients who come in who have kids, and I don't know how many of you in the audience have kids, but I think each individual parent has the same perception of their own kid, right? They're the smartest child in their class. They're the fastest child in their class. They're for sure the cutest child in their class. And so in the pediatric world, we hear those kind of things. In the adult world, I'm sure you kind of hear something similar like, I have a very high pain tolerance. I can take a lot of medication, and it doesn't really affect me. The other things we may hear is, my mom was big-boned, and I'm very big-boned. And in Kansas City, I can guarantee you that's the case, especially after going to Joe's Kansas City barbecue. But the thing that we hear an awful lot of is, I metabolize medications differently than everybody else. And I think that's one of those idioms and things that we get into when we hear that. We kind of shrug that off because we're not entirely sure what that really means. But whenever we look in our field, these are just a smattering or a small example of medications that are impacted by genes that are known about, that have clinical recommendations and guidelines to them that we as a field are not following or using yet. So if we're talking about oxycodone, variations within that CYP enzyme may cause increased levels of oxycodone, may cause decreased levels of oxycodone, depending on the rate that gets metabolized. When we're talking about selective serotonin reuptake inhibitors, that's metabolized by the CYP2D6 system, the most highly polymorphic CYP enzyme that we have. So some parents, whenever you have a kid, you're passing down that CYP enzyme in one gene from one parent, one gene from another parent. Some patients may end up with a non-functional enzyme and end up with a poor level of metabolism, so they would end up with an overexposure medication. Other patients may inherit multiple copies of that same enzyme that are hyperfunctioning or extensive metabolizers, so they may end up completely metabolizing through that level of medication before it ever gets to a level of therapeutic benefit. Also, so we've talked about the variability in level of exposures. There's also variability at level of target receptor sites. So not only do we need to get the medication to the right place, we need to get that medication to a receptor site that actually works, right? So if we never get it to that site that actually works, it's not going to be beneficial. So when you're talking about warfarin, the VKORC1 gene encodes for the target site that warfarin works at. In SSRIs, there's another target receptor site that has variability that we're able to test for and in a CLIA-approved laboratory and obtain information as to whether or not a patient may or may not benefit from SSRIs. Same thing when we're talking about propranolol, clonidine, omeprazole. So you can really look at this and see how much through the entire spectrum of PM&R, outpatient and inpatient, adults and pediatrics, we can impact our field with using precision medicine initiatives. And I think for us, the challenge not so much lies in developing all these new ideas, it's really escaping old ones. And so the first lesson I learned in the world of in the world of PM&R came on my inpatient brain unit rotation, which was my first day, July 1, 2000, I don't want to admit it, but it's I think 2010. And I think my brain injury attending started me off of that day saying, okay, Dr. McLaughlin, so the thing you want to do with all these medications is start low and go slow, right? I think every PM&R residency, that axiom is said over and over again. But when you do that, what does that come at the expense of? Anytime we're delaying treating somebody optimally, that's cost, healthcare costs that they're not able to use, right? That's trust that we may be losing because we're taking 2 years to titrate a medication to a beneficial level, right? That's ambiguity of care. So did what we actually do help whenever we got that SSRI to the right level? Was that a level of cognitive ability that got retained or was better after brain injury recovery? And so whenever we get to this category of what is the expense of starting low and going slow, without knowing about what precision medicine things we can be testing for beforehand, we lose out on a lot of patient care aspects of things that we're not able to do or we're not able to talk about before today. But in PM&R, our future is really bright with this. I think we are positioned at a really unique time in medicine. that for lots of us who practice this type of medicine, we're able to look at the full patient, the full spectrum of their total environment, their total nutrition, their total level of proteomics, their total level of the hyphen omics that happen within precision medicine that we need to be keyed in on whenever we're talking about how to properly prescribe a medication for the right patient. So I want to thank the Academy again for allowing me to talk on this. I want to thank you all for coming and staying on Friday. And finally, just want to say thank you to all my mentors. It was one of those things that without whom I would not be able to do this. So I truly have stood on the shoulders of giants. And obviously with my height, that has helped an awful lot. So thank you guys very much for allowing me to talk, and thanks for staying on Saturday. Thank you.